My name is Rhys Thomas and I'm an anaesthetist based in Newcastle, Australia. And this presentation describes some aspects of my journey from doctor to patient and back to doctor again that has happened over the last 5 years. And it all started in October 2013, less than a year after completing my anaesthetics training, and life was good. I was enjoying the relaxed lifestyle that Newcastle has to offer with my lovely wife and 3 kids, and doing all the usual stuff, going to work, hanging out with the kids, going to church, and even making it to the gym occasionally. But that all changed quite quickly, and it really was quite out of the blue. I'd had a couple of days off work with gastro, but I'd recovered over the weekend and got back to work the following week. But then I developed some flank and abdominal pain, and it was kind of worse the next morning. So I thought it might have been kidney stones maybe, or some complications from the gastro that I'd had. I wasn't too concerned by it, but I knew that our emergency department is quieter in the morning, so I thought I'd get it checked out before things got too busy. And I was well enough to drive myself to the hospital and saw a doctor. They'd organised some pain relief, some blood tests, and a chest x-ray. And it was at this point that things started going downhill. He came back a little while later, and the news wasn't good. He showed me the x-ray, and as an anaesthetist, the problem was immediately apparent to me. And yes, that big lump circled in red shouldn't be there. And obviously this is not what I was expecting, and things just continued to snowball from there, because I went on to have a CT scan, and it showed that as well as this big 9-centimetre mass in the left lung, there are a few smaller lung masses as well. There was also one in my adrenal gland, which probably explained the flank pain. And then there are numerous of these lesions scattered throughout my abdomen as well. But we needed tissue diagnosis to work out what it actually was. So a couple of days later, I went back to the hospital for a bronchoscopy and a biopsy of it as well. So this was on the Friday, and so there was an anxious wait over the weekend, waiting for the results, and we did what everyone else does in this kind of situation, and rushed out and got some family photos done. Here we are putting on a brave face, though it does seem that my daughter knew something wasn't quite right. And sadly, yes, back to reality and the doctors the following week, and he showed these photos from the bronchoscopy, and those brown things there are quite characteristic of melanoma, and that was confirmed on the pathology results that he had as well. So yes, it was a metastatic melanoma that I was diagnosed with, and as mentioned there in the letter, we didn't discuss prognosis at this appointment, but yes, I knew from bitter experience as a doctor that it wasn't going to be good. But I did quite like this bit about me being an astute doctor, so I'm thinking I might put this on my Twitter profile or LinkedIn or something like that. But in order to get a better idea of what my prognosis actually was, needed to do some further testing, and melanoma has a habit of spreading to the brain, and so an MRI was lined up for that. And yes, unfortunately the news wasn't good here. So you can see, go through the scans, that big white thing there, that's a melanoma that has spread to my brain, and you can see a few other ones there and some smaller ones scattered around the brain. So yes, it wasn't a good scan. And then this one here shows that black spot there, that's that large melanoma you saw, and then the white around it is the swelling and edema that it's caused, and it's starting to push on other structures around it. So as bad as the prognosis was before, the presence of these brain mets made it a whole lot worse. And subsequent discussion with my specialist revealed that the median survival for someone in my situation is about 3 to 4 months. And what this means is that if 100 patients like me with these melanomas presented with what I had, then 50 of them would be dead within 3 to 4 months. And not surprisingly, that large brain met that you saw, that was the most pressing issue. And the decision was made to have it removed by a craniotomy as soon as possible. So about less than a week later, I think I was back at the hospital where I'd originally presented and had the biopsy and bronchoscopy, and indeed where I'd done the majority of my training as a registrar and had been enjoying working there up until very recently. But at least I was able to provide the, professional courtesy of an easy bag mask ventilation and grade 1 intubation and some tram track hemodynamics during the anaesthetic for my friends and colleagues that were looking after me. And yes, fortunately the surgery and the anaesthetic and the recovery went off without any major complications, and I was home within a few days. But what now? There are melanomas everywhere. I've had the most imminent threat to life dealt with for now, but there are still lots of other brain mets there, as you saw. And chemotherapy provides little, if any, benefit really in melanoma, and it's very toxic, so that wasn't a viable option either. But this lack of a good treatment for a very common cancer, particularly in Australia, meant that there was lots of research going on in this area to try and find some new treatment options. And there are clinical trials. However, unfortunately, most of these excluded patients with brain metastases, so I was immediately ruled out of them once these mets had been identified. But one area showing some promise was what's known as targeted therapy, and essentially targeting specific pathways within cancer cells that were often overactive due to a mutation in their DNA. And in the case of melanoma, there had been some success with drugs that targeted this BRAF pathway. And this particular mutation is present in 50% or so of melanomas. So if my melanoma had this particular mutation, then there were some new drugs and clinical trials that might be available for me. And so now we had to wait around to see if my melanoma had this particular mutation. Because if it didn't, then there was no point starting these drugs, as they would be ineffective.
Now we play the waiting game. The waiting game sucks. Let's play Hungry Hungry Hippos.
And yes, I've had to play the waiting game many times in recent years, and I do have to agree with Homer. It really does suck. If for no other reason than I seem to lose it so often when I play, which unfortunately was the case here as well. My melanoma didn't have that BRAF mutation, so that treatment option and the clinical trials were ruled out as well. So between all of those brain mets and being BRAF negative, there are very few options remaining really. I was referred to a radiation oncologist, and the decision was made to start palliative whole brain radiotherapy. However, I was given the option of travelling 2 hours to Sydney to try a variation on the standard whole brain radiotherapy called integrated boost with hippocampal sparing. Now, this involved giving some extra radiation to some of those larger tumours that were still remaining, but trying to avoid radiating the hippocampus in the brain, which is with the hope that it might reduce the risk of longer-term neurological problems that can sometimes develop after whole brain radiotherapy. And even though I didn't think that I'd live long enough for this to be a problem for me, and the evidence at that stage was still relatively patchy, my doctor framed it in terms that I found quite helpful. And he said something like, if it were me, I'd be willing to travel the 2 hours to Sydney for it, but not if I needed to go overseas or something like that. So yes, I decided we'd go with that option. So I stayed at my parents' place in Sydney for the 3 weeks to have the 15 doses of the radiotherapy. But yeah, spending so much time away from home and the kids when I'd been given such a short life expectancy, it wasn't particularly ideal, but I was able to go back to Newcastle on weekends, and my family came and joined me for the last week of the treatment, and my kids had many and varied ways of coping with what was going on at this point, and this is my daughter playing with the mask that they used to stabilise my head during the radiation treatment and keep it still. It was custom made for me, so I was able to take it home at the end of the treatment as a rather morbid souvenir, but my daughter did seem to enjoy playing with it. And at this point, the default option for me was to finish off the course of radiotherapy after those 3 weeks, and then to start straight away onto a new drug that had just come onto the PBS in Australia. It was called Ipilimumab or Yervoy. And it had only been approved by the FDA in the US in 2011, but now in 2013 it had been fast-tracked onto the PBS because, as alluded to earlier, there really weren't any other treatment options available for melanoma. And it's a type of immunotherapy called a checkpoint inhibitor. And our immune system has a way of determining which cells are foreign and need to be destroyed, and which cells are self and need to be left alone. But unfortunately, many cancers have hijacked this checkpoint, meaning that the immune system doesn't recognize them as being cancer and so ignores them. But these checkpoint inhibitor drugs block this pathway and unmask the cancer, and then allow the immune system to attack it. And it was still early days with this drug Yervoy, but it had shown a 15 to 20% response, which isn't great, and its effect on brain mets was uncertain, but there were really no other alternatives, and it was now considered the standard treatment for advanced melanoma. But while I was down in Sydney having my radiotherapy, the melanoma unit in Newcastle had a closer look at this clinical trial, Checkmate 67, and thought it worth considering. So it was a randomised, double-blinded, placebo-controlled trial, and it had this default option of Yervoy as the control arm, and then a new type of immunotherapy, a different checkpoint inhibitor that was also showing promise called nivolumab or Opdivo as the intervention arm. And then it had a third arm in the trial that had both these two immunotherapy drugs in combination. But there was a catch. I couldn't start this trial straight away because one of the exclusion criteria was this active brain metastases. And in order to show that my brain mets weren't active, I would need to wait 8 weeks after the end of the radiotherapy, repeat the MRI, and then if the brain mets hadn't grown, I could start the trial. So I was presented with these two options, the so-called red pill or the blue pill. And so, yes, the first option was to start the Yervoy as soon as the radiotherapy had finished. The other option was to wait 8 weeks after finishing the radiotherapy, rescan, and then if stable, start the trial. If not, then I would just go back to the default option of the Yervoy. But need to bear in mind that there was a 1 in 3 chance that even if I did qualify for the trial, I would end up being randomised to just the Yervoy anyway. And as you can imagine, 8 weeks is a long time to just twiddle your thumbs and do nothing if your life expectancy is probably somewhere south of 6 months. So how did I decide? Well, there were, I guess, a few things that I kind of took into consideration or was thinking about. And firstly was this concept or idea, the Hawthorne Effect or trials effect that's been noticed, which suggests that patients in clinical trials, even those on the control or the placebo arm, do better than those that aren't in trials. So I was keen to get on any clinical trial I could, and the early results on Opdivo were promising, and this trial was really the only chance that I had to get access to that drug, as it wasn't widely available yet. And as an interesting side point, that Hawthorne player there, Jared Ruffhead, he was subsequently diagnosed with melanoma himself and ended up on one of these checkpoint inhibitors. Secondly, or the other thing I took into consideration, as the meme goes, because science. From my undergraduate biochem days through into med school and into anaesthetic world, I was aware of the importance of scientific research and clinical trials in healthcare, and I thought that if there was an opportunity for me to contribute a data point or two to the body of science out there, then I should take it. And I like to think that my data points have achieved both statistical and clinical significance. And finally, knowing that, well, like most cancers, there's a genetic component to melanoma, and that it can run through families, I figured that even if it was too late to have any impact on me, taking part in a clinical trial would add to the body of research that may one day be of benefit to my kids. So in the end, the decision to try and get on the trial was a relatively easy one, even with that prospect of an 8-week wait. And indeed, due to some of the side effects that I subsequently experienced, I can now confirm the truthfulness of this meme, unfortunately. And so, yeah, this was before the days of Netflix in Australia, so it was back to Hungry Hippos. Although I did, find some other ways to fill the time. This was actually a Christmas present that my wife had bought for me before I was actually diagnosed with the melanoma. So one of many examples of divine providence during this difficult time. So had some fun putting that together with the kids, and this is the finished product here. But yes, I was only 4 weeks into this 8-week waiting game when it was interrupted by another trip to the ED. This time I rocked up with fever and vomiting. Overnight that evening I developed some abdominal pain, and then I ended up in the operating theatre the next day, and again it was more bad news. There was basically melanoma everywhere, and it had caused a bowel obstruction. I ended up with a right hemicolectomy, so they removed half of my large bowel, and then also removed some sections of my small bowel, and then basically zapped with the diathermy any melanoma that they weren't able to cut out that they could find. And it was during this admission that my health really started to deteriorate. I lost about 10 kilograms, and after discharge I continued to struggle to keep food down. I had ongoing diarrhea, my exercise tolerance was very limited, and I was more or less housebound. I couldn't drive because of the brain mets, not that I was kind of really feeling up to it anyway. But when I got to the 8-week mark post-radiotherapy, I finally got some good news. The brain mets were stable, and so I could start the trial. But I was still very unwell from the bowel surgery at this point. And as they say, a picture paints 1,000 words. And so this is the photo taken at the time of diagnosis in October 2013, whereas these photos were taken in early April, about 2 months after the laparotomy and a month after the trial had started. So you can see there's quite a significant difference between the two. And this wasn't even at my worst. I was readmitted a few weeks after these photos with another bowel obstruction, another laparotomy, another week in hospital, and another 5 kilograms or so of weight loss during that admission. And I was very malnourished. These are some of my blood results from that admission. And the most obvious thing is that there's a lot of red there, which shows an abnormal result. And they wanted to start TPN, or feeding me through central line, but they had to delay it because my potassium and phosphate and magnesium were so out of whack that I was at risk of refeeding syndrome. But yeah, as you can imagine, at this stage I was also very miserable. I had bad anxiety, depression, and insomnia, and this meant that during this admission, when the CT scan revealed that the tumours had started shrinking, I found that I couldn't really celebrate with everyone else because from my point of view, I was still going to die from this melanoma, but it just meant that it was going to drag on a bit longer than I thought. And given how horrible I was feeling at the time, both physically and mentally, that wasn't an especially pleasant thought. But they eventually got me well enough in some sense to discharge me, but I continued to have ongoing trouble with poor appetite, couldn't keep food down, and at my worst I dropped down from a starting weight of just over 85 kilograms down to about 60. And then, to add insult to injury, my hair started going grey. And as a result, I now have a new favourite Bible verse from Proverbs. It says that grey hair is a crown of splendour. It is attained in the way of righteousness. And as it turns out, this was actually another sign that the drugs were working, because this kind of vitiligo or depigmentation had showed some correlation with improved survival in patients such as myself. But then going into the second half of 2014, things slowly but surely started to improve. There was no dramatic step change, but over time I was able to keep more food down, started putting on a bit of weight and get a bit more active. And the tumours continued to shrink, and some of the smaller ones had even disappeared. And then in 2015, the first results from my trial came out showing that these drugs were actually living up to some of the promise that they showed in earlier trials. And with somewhere around 50% of patients responding to this new drug Opdivo, and some of those patients even having a complete response with no evidence of residual disease, which was quite remarkable. And it needs to be remembered that even the control drug in this trial, Yervoy, was itself a breakthrough, and it had only been recently on the market. And so the nearly 20% response that it showed is also a good result, and shows, along with some other medications that have come on the market, how the treatment options for melanoma, how far they'd come in just the space of a few years. And indeed, these results were so remarkable that it led the New Scientist magazine to wonder if this could be considered cancer's penicillin moment, because as well as melanoma, these drugs were also having a big impact in other cancers too. And so, yes, now what? The drugs seemed to be working, the tumours had shrunk, and I was feeling a bit better. And so all of a sudden, the thought or the prospect of returning to work, which seemed impossible at the time of diagnosis, now seemed to be viable again. But I knew that there would be some hoops to jump through. So I went back and saw my doctors again, got their input. My neurologist suggested that I get an opinion from a neuropsychologist. I'd not had a stroke or seizure, but given the neurosurgery and radiotherapy, as well as the fact that the brain mets hadn't completely resolved, it seemed a sensible thing to do. And it was quite an interesting experience, actually. It involved about 5 hours of this kind of testing, looking at things such as the Stroop effect there, sentence completion and response inhibition, as well as numerous verbal and visual memory tasks and that sort of thing. And the tasks and questions would just keep getting harder until you started getting them wrong, so that they could discriminate the level that you're at. And by the end, I'd made a lot of mistakes and really had no idea how well I'd done, but apparently I did enough and was able to continue on the return to work journey. I also had to accumulate some CPD points, and there are a number of ways I did that. But one in particular that I recommend for anyone going through this return to work practice like I have is the crash course in Melbourne. It was really a very good thing and well worth doing. And once I'd had those medical reviews and had enough CPD points and so on, I submitted a return to work plan with ANZCA, and then applied and got my registration back from APRA. So this was back in late 2016, and I'm still on the clinical trial at this point, with regular medical appointments and blood tests, infusions, and ongoing side effects. But yes, I was able to get back into some unpaid, directly supervised work at John Hunter, and over time was able to increase my workload and decrease my supervision, and basically got back to working independently again and getting paid. But yes, I was careful to limit myself to in-hours work, so no on-call at John Hunter, and only in a part-time capacity. And I know that sounds really tough. But in addition to this, without going into the details here, I also took on a new non-clinical role at John Hunter as the inaugural Quality and Safety Fellow in the Anaesthetic Department. And if you're interested in finding out more about this, you can look up this presentation that I gave in early 2018 at the ANSCA annual scientific meeting. And John Hunter have been very good in providing me the necessary flexibility to combine the clinical and non-clinical aspects of working, along with the ongoing medical treatments and all that involves as well. And so that's been very helpful in the return to work process. And while my story continues to have many twists and turns, for whatever reason, the 5-year survival is a common metric that's used when talking about cancers. And I reached that milestone just yesterday, actually, on the 30th of October 2018. And interestingly, that day also began with a drive to John Hunter Hospital, just like 5 years ago. But instead of the emergency department, it was to a nursing CME meeting in order to, or partly to thank them for their participation in a research project that I'm currently working on, but also to update them about our near-miss reporting system, which I've been involved with in my quality and safety job, and also to let them know about our new Breaking the Rules for Better Care project that we've just launched. And then went to a meeting on infection control and perioperative attire, and picked up the kids from school and went for ice cream. And it was all very nicely mundane. But then on the flip side, I've got my next batch of scans next week, which will trigger the usual scanxiety. There's no immunotherapy infusion this week. I had to stop the trial due to ongoing side effects, which unfortunately have also kept me out of clinical work this year and left me wondering how feasible it will be to maintain the clinical side of my job in the long term. Or perhaps maybe I would be better off pursuing further study along the human factors and patient safety lines that I've really been enjoying in recent times. And I'm very much at the pointy end of the data on these new drugs, which makes planning for the future very difficult. But I'm certainly very thankful for the extra 5 years that I've been given so far. It's been great getting to see my kids grow up a bit, and I was fortunately well enough to enjoy a trip to Tasmania with them all recently, which, as you can see here, we were very sad to see the end of that holiday. And I've seen a lot of prayers answered over the 5 years, and I've still got my crown of splendour. And I've enjoyed a lot of support from many doctors and nurses and family and friends, as well as my church community. And certainly my time playing the waiting game as a patient many times over the last 5 years has indeed taught me to be patient. And I hope that wherever I end up professionally in coming years, that my experience as a patient will in fact make me a better and a more patient doctor. So thank you for listening and taking the time to hear my story. I hope that you've got something out of it. And if you are interested in chatting to me more about this, I'm happy for you to get in contact with me. And probably the best way to do that is via Twitter, where my handle is @DrGetAFix. Thank you.